everyone a couple more minutes to join before we get started. Okay, guys, so thanks so much for joining. I think we're going to go ahead and get started. We really appreciate everyone that's had a chance to join, and we're looking forward to a great session. So my name is Sara Liaghati Mobarhan. I'm a newborn health innovation specialist working with UNICEF Supply Division. And welcome to the next in the series on the health system building blocks learning sessions. So this is, as you guys know, centered around the different building blocks and is linked to the NEST 360 UNICEF co-developed and co-published Newborn Toolkit. I believe we'll be putting that link in the chat so that you guys have access to it. And if you're not already, go ahead and sign up for the Toolkit newsletter so that you can be aware of the different sessions that we're having around this. This is the second HSBB learning session of the year and focused on infrastructure. So we'll be going through the different infrastructure that supports effective and safe oxygen systems. And yeah, looking forward to a great session. So as we go through the different talks that these amazing speakers have prepared for y'all, each speaker will be introducing themselves. If you have any questions or any comments, you can ask them in the Q&A section section of the Zoom. So yeah, with that, I think we can hand over to our first speaker.
Great, thank you very much, Sarah, for starting us off. My name is Jane Briggs, and I work on the USAID funded program called Medicines, Technologies and Pharmaceutical Services, which is abbreviated to MTaPS. And I would like to talk to you today about the importance of assuring quality of medical oxygen and a new technical resource that we have just been developing, and how you can get involved in that if you are interested to. So the next slide, please. And moving on to the next slide. So I think everybody, particularly through the pandemic, but also particularly this group of people that is interested in newborn care, we're aware of the importance of oxygen, that it should be available, that it should be accessible to the patient when it's needed. But what we want to highlight today is the importance of assuring the quality of oxygen, so that quality assurance practices have to be maintained throughout that whole oxygen supply ecosystem to make sure that the oxygen that is available and accessible to the patient is also of acceptable and consistent quality. Management of oxygen systems, as we all know, comprise a multitude of different activities, from systems planning, manufacturing, procurement of goods and services, regulation of medicines and medical devices, operational procedures. And particularly in response to the COVID pandemic, there has been a huge increase in international guidance and technical resources related to the oxygen ecosystem. But what we noticed is that there has been a real gap in terms of technical resources to look at how to assure the quality of that oxygen. So after many discussions with WHO and with our colleagues at USAID, we decided that it would be helpful to develop a technical resource document that really looks at how to assure the quality of medical oxygen from the point where it's manufactured and leaves either an industrial manufacturing production plant, or where it's actually managed going through the manufacturer actually in a hospital where there are PSA plants in a hospital itself, and then looking at the whole chain of oxygen supply up to the point of the administration to the patient, to make sure that where at each point along that chain, quality assurance practices are applied. Next slide, please. So the document that we have developed and is currently under review, and if you have not been part of our stakeholder review process and after listening to this presentation you would like to, please reach out to us. We have developed the first draft. We've been receiving comments from a wide group of stakeholders. And so if you would like to take a look and send in your comments, we can certainly share that with you. And then next week, we're planning a virtual consultation to address some kind of pending issues that are easier resolved in a discussion format before we finalize the document by the middle of April. So let me talk you through a little bit what the document looks like. The structure of the document goes through several sections, and it's important to note that this document is intended to complement existing resources and guideline documents, particularly from WHO, but also from other publishers. And so the document itself starts off going through a number of different important sort of context before we go into actually the quality assurance piece. First of all, giving an overview of an oxygen system, what that looks like, then looking at what quality systems are all about and how that's related to oxygen. And then we spend some time in the document talking about the quality requirements of medical oxygen. And that's dictated by, first of all, the pharmacopoeia, WHO's international pharmacopoeia, and of course, also other pharmacopoeias from other well-resourced countries, from other stringent regulatory authorities. We also mention good manufacturing practice, not in this context that it's applicable to industrial manufacturers of medical oxygen, but where it applies to where there's on-site production of oxygen, for example, through PSA plants at a hospital level. And then the real meat of the document is this section on applying quality assurance practices along the supply chain of oxygen. And you can see here all these different domains that we talk about for how to apply quality assurance practices. Next slide, please. So going into those domains in a little bit more detail, this is the chunk of the document that really talks about how quality assurance can be applied, maintained, and monitored across these different domains. So here on this first slide, we're looking at the domains of personnel. So here we're talking about capacity, the type of people that are involved, the cadres of people that are involved in the oxygen supply chain. And that's not just limited to facility staff within a health facility, but also external stakeholders. So for example, those in the production unit, transporters, suppliers, regulatory authorities, both from the government, the private sector with transportation, and NGOs as well. Another domain is premise and equipment, and here we need to make sure that there is purpose-built infrastructure and equipment for medical oxygen, and it has the requisite safety features. And so we talk about the management, the maintenance and repair of the premise and the equipment and the infrastructure that's needed. Then going into the area of source-specific requirements, here we're talking about oxygen that's either produced on site, like I say, in a hospital production plant, or is procured. And we need to make sure that that medical oxygen is of acceptable quality in terms of its identity and purity, and that it's handled and stored correctly. Transportation and storage is obviously a big thing, particularly if hospitals are procuring from industrial manufacturers of medical oxygen. And because oxygen is a medicine, good distribution practices need to be applied so that the oxygen quality is assured. Next slide. The other domains where we still have to be conscious of how to apply quality assurance practices is documentation and record keeping. There should be standard operating procedures and work instructions to make sure that there is continuous and uniform practices and processes that are applied. And there has to be good record keeping to track these activities and their outcomes. All of this is important in terms of assuring the quality of the product. Quality control is obviously important when we're talking about the production in a hospital facility, and there needs to be appropriate testing of the oxygen with appropriate equipment at a frequency that is appropriate, and that should be done by people that are not involved in the production of the oxygen itself. There obviously has to be a complaints and recall system. There needs to be appropriate channels that if there are any issues that arise regarding the medical oxygen in the unit, that can be communicated appropriately to facilitate recall when and if necessary. And then lastly, the area of self-auditing. So there has to be reviews of the health facilities oxygen supply chain to ensure the continuity of the production, but also the delivery of a quality assured product. So this is the section that talks about quality assurance practices. And then in the next slide, I'll show you some additional resources that we've added onto this technical resource. So we did not want this just to be a kind of theoretical reference document. We wanted this to be something that was practical and helpful for people that are dealing with oxygen in whatever their role is within that whole ecosystem of oxygen. So the first set of annexes we have included in this document are a set of supplements that are talking about quality assurance practices that are specific to certain roles. So we have some examples of checklists that have been developed for specific roles that detail activities, specific action items, how often those actions should be applied, and the documentation that's needed. And so moving on to the next slides fairly quickly, we can run through, I'm not going to go into these in details. If you'd like to take a look at the document, you'll see them. There's some checklists for different types of people that are involved in the supply chain. So here we have a checklist for the regulatory authority. The next slide shows a checklist for the head of production in a hospital unit. And the next slide shows a checklist for quality controllers. And so each of these checklists show the activity, what they actually need to do, how frequently, how often that should be done, and what is needed to document that it is done. And all of that's important for assuring the quality. The other annex that we have that is another useful tool is shown in the next slide. We show some templates for recording the quality of oxygen, for example, when it's produced on site. And so in the annexes we have, the next slide shows a template that can be used for on-site oxygen generation. So on the left side of the slide, you can see that there is the blank template. And then on the right side is an example of how that template is filled out. And then we also have a template for cylinder filling, the next slide. Again, the template on the one side, and then the example on the other side to show how this is a useful template to be filled out for each batch of cylinders that's being filled. So these are important record-keeping documentation examples that are part of the quality assurance process. And then the last example we have is a certificate of analysis for the case of, and the next slide, please. An example of a certificate analysis for the case of liquid oxygen. So we feel that the main text of the document goes through all of the theory and how to apply quality assurance throughout the whole supply chain. But the annexes, which sometimes when you're reading a document, the annexes are the bits that you skip over. But in this document, the annexes are really the practical tools that country stakeholders at different levels within the supply chain can use to make sure that we're making sure that oxygen is of the appropriate quality. So just to finish off in the next couple of slides to show that this, one last thing in the annex is, yes, what we've tried to do in the next slide, we have tried to, could you show the next slide, please, Mita? We've tried to map here onto the standard operating procedures. Here's an example of a PSA plant startup with the standard operating procedures. What are the different steps of the operational procedures? We've tried to overlay on that at different points in those procedures where there are quality assurance practices that need to be applied that fit into those procedures. So there's going to be some examples of that in the document as well. So moving on to the next slide, just to show this document builds on a number of complementary resources. All of these are linked in the presentation if you want to take a look at that later. And on the next slide, another set of resources, building on, of course, the broad range of documents and resources that WHO have been producing recently, and particularly in the response to the COVID pandemic. So again, this resource is under development. If you would like to take a look at it and feed into the consultative review process, please feel free to reach out to me. As I say, next week, we'll be having a stakeholder virtual discussion to look at some particular issues that have come up in the review so that we can move on to finalize this document. And part of that discussion next week will also be how this can be useful at the country level, and what's a good dissemination strategy, and how can we work through people like yourselves so that this document can be used by all the different stakeholders that are involved in the oxygen supply chain in the countries where we're working. So that's it. Thank you very much. Do follow up with me if you have any other questions. Thank you. So now I'm going to pass over to the next speaker in this wonderful panel. And so we have Norman from the Ministry of Health in Malawi, who's going to talk to us about a national oxygen roadmap and the process of that. Norman, over to you.
Norman, you're on mute.
Okay, fine. Good morning, good evening, good afternoon, wherever you are. My name is Norman. I work with the Ministry of Health, and I've been doing the oxygen work for some time now. And it happened that in 2021, we launched, the Ministry of Health launched the oxygen roadmap with the different support from different partners like PATH, UNICEF, WHO, and others. So when we launched the oxygen roadmap, we first did the survey for the biomedical survey, which identified the gaps where we are. And I'll use this slide to make sure that we are following that, because we have called it the National Oxygen Ecosystem Roadmap, which means when we are working, we are not working on one system, but we are working on several systems, so that at the end of the day, we have one system, which is very important, and making sure that we are offering care to patients based on quality care to patients wherever we are giving oxygen. So on the infrastructure, one of the major problems, challenges which we had was infrastructure. When COVID did hit us, we had troubles finding oxygen, and we thought that we should make sure that we provide infrastructure for oxygen. So as a country, we said we should go on and say, let's put up oxygen plants, and we have tried our best. At the moment, we have several plants operational, and we have several others which are not in operation, which are in the pipeline. But by the end of the year or two, we should be having almost 15 oxygen plants in the country. And now we are thinking about how best can we put the infrastructure, where we have been running around with these oxygen cylinders. We saw that we should be able to make sure that we have oxygen piping systems in our facilities. So we are working towards that, and currently we have funding to do more facilities to make sure that all the government district hospitals, which are about 28 in number, to be piped, and the rural hospitals also to be piped. We're in good negotiation with different partners. And on the same piping, we thought that I think that's very important. So we have those things, making sure that we are making oxygen safer and easier to be provided to our patients. So we are looking at the stem piping production of oxygen up to the end user where we are going to use oxygen. Then the next thing after production is the information system, which I think my previous Jen has previously said, we need an information system. So as a country, we have championed the production of the development of indicators, oxygen indicators. We have looked at the indicators on the production, the supply, and the use side, so that we can make sure that we are following all the roadmap, we are following all the work which we have. And to that, we have successfully developed the indicators, and they are almost complete. And we have also embedded them into the medical record system for one of the major central hospitals, so that at the end of the day, once we learn from that, we can now put up the system across the whole health system. On human resources, it's also another important thing, and we realize that we have gaps in the human resources. People are not doing the right things at the right time. So what we have done at the moment, we have trained health workers in the management of emergency and critical care, which included, during the COVID era, which included oxygen management as the main component. So we have guidelines, we have developed guidelines and made sure that we are working properly to make sure that we are doing that. And currently, we have several partners who are also supporting us to make sure that we achieve these goals. So we have PATH, UNICEF, we have the World Bank, we have WHO, all of that coming up to help us develop the human resource capacity. We also looked into the governance and leadership to make sure that we are doing the right things at the right time. So in the governance, we have developed our SOPs, and I was looking at what the previous speaker was presenting to say, we need at least to our SOPs and our documents, we need to make sure that we are also referring to that document. So I'll be interested to see that document soon. So we have developed the SOPs, and currently we are also looking at the standards, SOPs for development of oxygen and SOPs for the use of oxygen. And we are also moving up to say, do we need to develop standards? And once we develop the standards, we are also going to make sure that we are moving towards regulation of oxygen, so that all the oxygen which is used used in Malawi, we can make sure that we have that, and it's according to the standards, and we are not interfering. We are not providing things which can kill patients. And at the end of the day, we are going to base on the standard to make sure that we have supervisory visits and mentorship and all that embedded into our system. On that, on the leadership and governance, we are now remaining with development of the supply, the supply chain, logistics chain, which we need now. The World Bank has given us some funding to test the hub and the spoke model, whereby we are going to look and say, how best can we distribute oxygen in a specific area and later in the whole country. I will move on to medical supplies, and I will jump about infectious prevention. We are making sure that we control we make sure we are using the infection prevention techniques to make sure that oxygen is provided to patients, which is safe and using the right things. On medical supplies and devices, this is a very critical issue which we are using. We are going to be working to make sure that we have appropriate mix of technologies at all areas. We have, at the moment, deployed pulse oximeters to almost all district hospitals. Despite that, we did not do that because UNICEF gave us some pulse oximeters. We still need a huge need of pulse oximeters at that. And we know that PATH is also, we are working also with PATH World Bank to make sure we procure pulse oximeters and send it to the districts. We are also empowering the biomedical engineers. We have trained biomedical engineers in the use of respiratory care equipment and the repair of respiratory care equipment. That's what we are doing in Malawi. And we, on the financing, that's another major issue which we are doing on the financing. We are currently being funded by different partners, government, but we are thinking now that since WHO has made medicine as a drug, which I think we are so thankful to that, we are looking at the financing mechanisms, where local financing mechanisms, which we are going to see and say, how best do we finance the oxygen system? With several oxygen plants, we need to start thinking on how best do we generate local resources to maintain the oxygen plants, to train biomedical engineers, to develop capacity of health workers. So we are thinking together with our partners, say, can we start thinking, strategizing on how best do we do oxygen, where do we finance oxygen as a medicine? And at the end of the day, we are thinking that we are going to really have family-centered care, which we have provided to the health workers, to the people of Malawi, and moving forward. So despite having the challenges, in conclusion, I can say that together with our partners, we have managed to launch the oxygen roadmap, start working on the roadmap. And I think having 1 year in the roadmap, in the implementation of the roadmap, we think that we have made progress. And we hope that we are going to sustain this progress and move forward. Thank you so much. I can pass over to the next presenter. Thank you.
Thank you, Norman. Thank you, Rita. So hello, everyone. My name is Belinda Nimako, and I work as the COVID-19 response manager for USAID Ghana. It's a pleasure to be presenting the work we've been doing following COVID outbreak here in Ghana in oxygen, and subsequently tailoring that to maternal and child health needs on behalf of the mission. Next slide, please. So yes, our topic is COVID-19, the silver lining, leveraging oxygen investment to bring oxygen to mothers, newborns, and children. So when COVID hit, we saw an opportunity, and that opportunity was to provide lots and lots of oxygen as the country needed, because what COVID did was to unearth various gaps in our oxygen landscape, not just in terms of the volumes of oxygen that was required, but in some instances, the form in which it was. Please, next slide. So before I tell you about our work, here's Portia, and Portia is one of the beneficiaries of our oxygen investments here in Ghana. She went into preterm labor, and like most babies that are born prematurely, her baby needed oxygen. Thankfully, she was in one of the facilities that we had a PSA plant installed in, and both Portia and her precious baby survived. If you want to know more about Portia's experience, as well as that of many other beneficiaries of our oxygen investments, please, we'll be pasting the link in the chat. Let's go to the next slide, please. So by way of context, Ghana has quite a high rate of newborn deaths. In fact, we say that it's estimated that a newborn dies every 15 minutes in Ghana, which is alarming, understandably. And our neonatal mortality rate presently stands at about 23 per 1,000 live births, far in excess of the SDG targets. Similarly, we have high stillbirth rates of 22 per 1,000. Mostly the causes of these deaths are preterm, birth asphyxia, and the third cause is sepsis. Unfortunately, we've not been progressing as speedily as we would like to. To meet our SDG targets, we need to be having an average rate of reduction of about 7. Currently, we are at 2.5. So what that means is we need to triple our steps, not just double our steps. And over the time, there's been a lot of investigation trying to understand what the drivers of this high mortality is. And considering we have a high skilled birth rate, it's obvious that most of these deaths occur in facilities. And so the focus has been on how to provide quality care within our health facilities. And as we all know, this can only be possible if we also have adequate oxygen, such that babies needing advanced respiratory support are supported within our health facilities. So this is the context within which we are working in Ghana. Next slide. So once COVID hit, we, as I mentioned earlier, many gaps were unearthed related to oxygen, some of which both Jane and Norman have highlighted in their presentation. In Ghana, one, we realized that there wasn't any regulatory policy on medical oxygen, whether is there where you can source it, how it should be distributed, and quality assurance, which Jane has spoken to us extensively on. We also didn't have data on oxygen needs. So how much do we need in which facility in total? How much are we generating presently? There was just no data on that. And to a large extent, most of the oxygen sources that were available weren't in the form that we needed for COVID. So they were mostly low flow, low pressure concentrators that had been donated by various partners over the years. Additionally, the health workforce had challenges. They had limited competency in managing medical oxygen equipment. And sadly, the few equipment that were even in the system were also not being maintained adequately. I think I'd like to focus on how most health facilities were sourcing oxygen. And for most people, they were dependent on private vendors for oxygen, people who were producing for industrial purposes. And as Jane mentioned, that this came with quality challenges. In addition to that, it came with high costs because often they had to travel over several kilometers to source this oxygen. And these organizations were working for profit. So ultimately, the cost gets passed on to the patients, and facilities had intermittent shortages. So this was the oxygen situation that COVID unearthed. Next slide. So what we did here in USAID, taking advantage of the ARPA funds that were available, the Global VAX funds and the Global Fund TA funds, we decided to support to help strengthen Ghana's medical oxygen ecosystem, working with our partners, RISE, Chemonics, and also working directly with our government partners, both at the Ministry of Health and the Ghana Health Service, which is the main service delivery agency in Ghana. Next slide. So within the mission, we took a system strengthening approach to our work. First, we focused on leadership and governance because, as I mentioned earlier, one of the gaps had to do with just the lack of regulatory policies and coordination, proper coordination of the oxygen ecosystem. So the mission supported the oxygen operational plan and policy documents. In addition to that, as I mentioned, we helped quantify the oxygen needs of the country. Then we also supported medical oxygen equipment infrastructure in the country, identifying places that we wanted to prioritize to receive PSA plants. Across the country so far, we have installed 4 PSA plants. A 5th PSA plant is on way, and we are hoping to install that sometime in May this year. Besides these PSA plants, we also have started a process to deploy liquid oxygen systems in 11 health facilities across the country, which will serve about 2,600 beds across a number of regions in the country. We also provided 50 ventilators, 28 concentrators, and then a lot of oxygen-related consumables also. We did not only provide these equipments, but we also dovetailed into oxygen workforce development. As has been mentioned, I think our situation here in Ghana is or was similar to Malawi situation. So we had biomedical engineers who had limited knowledge of how to maintain medical oxygen equipment. They needed to be trained. Health personnel had to be trained in oxygen therapy. And then to cement all these, we fostered a lot of partnerships. So the picture there probably is small, but Leah, who is handling the Q&A session today, was in country from USAID DC. We had our partners from Chemonics, people from international NGO, the government sector, clinicians, and we just built a lot of relationships, even with other players in the oxygen ecosystem, like other development partners, just to help coordinate the the medical oxygen ecosystem further. So this was the approach that we took to our oxygen work. Please, next slide. Now, having done all these, further down the lane last year, we started critically thinking about how to optimize our oxygen investments for maternal and child health. Hitherto, we had been quite strategic in where we placed our oxygen equipments in places with high need. Subsequently, now that we had MCH firmly on our radar, we spoke with our government partners, our in-house MCH experts, to decide places that had the most need, where they could also benefit from the oxygen plants or the liquid oxygen systems that we'll be installing. Along the line, we've also sought to make modifications to ensure that the oxygen that we've provided in various health facilities across the country are available for essential services, including maternal and newborn care. And what that means is, in some cases, we've had to do additional piping or to look for funding for additional piping works. We are also, to understand the whole oxygen ecosystem better, we've also commissioned a number of assessments, one of which includes a multi-country study to unpack the oxygen needs so far as maternal and child health. This health facility assessments is questioned. Also a comprehensive assessment to understand how we can sustain the oxygen investments we've made going forward. And then finally, we are also would be conducting trainings through our implementing partner, Jipaigo Rise, for clinical providers. And for these clinicians, hitherto you would realize that we're focusing on ICU staff, physicians, etc. But now a big part of that group would be midwives, training them on oxygen therapy, since the focus now is to optimize our oxygen investments for MCH. Next slide. So to wrap up, I'd like to walk you through one of our facilities where we deployed a PSA plant, Tamale West Hospital, and to demonstrate to you how over time we've sought to converge our oxygen investment with our MCH priorities. So Tamale West Hospital is in the northern region of Ghana, and is actually located in one of our zones of influence, very high volume health facility conducting over 6,000 deliveries per annum. And it was strategically selected because of its location. There was a high need in that region in terms of poorer clinical outcomes, fewer oxygen sources, etc. So having deployed our oxygen system there, because initially the focus was on COVID management, the piping was only done to the COVID treatment center, which is now actually serving as a meal ward. Once we came in with that scope, that lens to optimize that investment for MCH, we are actually going through processes of approving funds to extend the piping to other areas, service areas, including the labor ward and the NICU. For now, what the facility does is to use cylinders and transport it to those sites. The investments in Tamale West Hospital has been really impactful because the hospital has been providing oxygen to over 20 health facilities within northern Ghana. And since the PSA plant was installed at the facility, it is actually served out over 1,600 cylinders of oxygen. The exciting thing is it actually charges less than you would note on the open market, whereas the open market is charging about $12 for a cylinder. Tamale West is charging about $8. So that's one of the advantages. Plus, it's more guaranteed. You can vouch for the quality of the oxygen. And the great thing is, as I mentioned earlier, one of the challenges that the country had was that even the few oxygen facilities available were not being carefully maintained. Tamale West Hospital has really demonstrated leadership in that regard, where the regional director of health has set up a committee, and the oxygen they are supplying to various facilities, the money is being kept with the view of using it to maintain the PSA plans once the year warranty runs out. And as I mentioned earlier, we are also going through processes to find additional funds to extend the piping from just the COVID treatment center to the NICU and the labor ward, as well as provide additional NICU commodities that are needed to ensure that the PSA plans that we've provided, that we've installed at the facility, actually is used and provides oxygen at the points of the most need within the mothers and babies units and in the NICU setups. So this is the case of Tamale West Hospital, how we've gone through from the COVID era, installing PSA plans all through till now that we're trying to optimize it for our mothers and the newborns. With that, I come to the last slide. And this is the last slide by one of the medical directors for one of our health facilities, the Cape Coast Hospital, after recounting to us how because of the readily available oxygen in Cape Coast Metropolitan Hospital, they were able to save the life of a mother that had abruptio placenta, not just the life of the mother, but also the newborn. One good thing he said was that now his hospital does not refer patients because of shortage of oxygen, because that was the case when they weren't, they didn't have oxygen on site, and they had to transport it from various locations to their health facilities. Thank you. Over.
Thank you so much, Belinda, and thank you so much to all the speakers for your time and all the work you've done to improve oxygen access to mothers, newborns, children, and all patients in need. Before we start the Q&A and discussion, I want to just thank NEST for all their work to highlight the need of the small and sick newborn, and to remind all of us on here on this webinar, as we all know, that without improving care at the level 2, countries will not reach the Sustainable Development Goals for 2030. So with that in mind, Sara and I would like to help moderate the Q&A discussion. We had 3 questions in the Q&A function, and I would like to start with Nina Kaka, who had asked a question about to Jane Briggs. Nina, do you want to jump in and ask your question? Over. Maybe Nina's no longer. Oh, there she is.
No,
Okay.
I'm here, but I didn't know how to unmute myself. Sorry. Yes, thank you for the fantastic presentations. I was like, when Jane was presenting on her resources, I was so amazed that this is coming out, because this is going to be such a rich resource for countries as they have moved towards, gearing up on oxygen supplies. And knowing a few of the our low and middle income countries, I was wondering whether those tools can be shared with them, whether it works for them and is acceptable. And I was hence asking whether there's a plan to pre-test these tools and think about opportunities together about, using some of our momentum country and global leadership project sites to maybe use those tools. So that was me. And I think Jane responded to me, but any information that you might want to share with others.
No, thanks for that question, Nina, and nice to be in touch with you again. I think that this is exactly what we want to generate through this kind of forum, and we have shared the draft document for review by a number of stakeholders in different lower middle income countries, but obviously this is still at a draft stage. So I think once we've incorporated all those comments and got a final document, it would be great to work with you to maybe identify countries that could be a priority across both projects. We're still getting confirmation of the use of our funds under USAID, under the MTaPS project, to see how we can work to disseminate this resource once it's finalized. We did have in our plan that we would work sort of more closely with one country, sort of a country stakeholder workshop in country, but then also some kind of virtual orientation to a number of other countries, which would obviously widen the breadth of the dissemination to other countries. But I think that this is a great start to that discussion, and we can have discussions across projects to see how we can support. But I think, you know, once the document is finalized, then obviously it'll be on a number of different websites, and we can talk with Nest and see where we can house this in addition to it just being on our own project website, so that countries can download it and use it. It should not be a resource that's particularly complicated. The idea is that this would be a resource that is kind of self-explanatory, and so with the practical tools in the annex and kind of like the context and the theory of how to apply quality assurance, it should be fairly straightforward to adopt. But I think, yeah, it's important to see how we can get it out there and used. Both of the speakers talking from Ghana and Malawi talked about the importance of quality assurance for oxygen. So it's obviously a gap, and there's a felt need for it. So thanks for your comment.
Thanks so much, Jane, for answering that. I think we're going to take Dr. Roshan's question next. So that's directed, Norman, to you. What type of financing mechanism is planned by Malawi? Noting that it's a very complicated structure to keep the oxygen generation plants operational for a hospital. Norman, do you want to go ahead?
Yeah, thank you, Sara. At the moment, we as a ministry, we had to stop and start thinking about, we have all these oxygen plants around, and we have the system which we have to develop to make sure that things are working. And we should not start crying at the end of the day. We have learned from one of the facilities, which is in the North Malawi, whereby we have the oxygen plant breaking it down, and we can't do something which is better. So what we are thinking as a ministry is to start, can we start thinking about how best can we start generating resources from the same oxygen plants? Because I think if we can start generating that, and we are happy that the WHO made oxygen a medicine, because we are going to start thinking about the facilities going to buy oxygen, not to buy oxygen, to contribute a certain fee to the facilities, a maintenance fee, which we are thinking. But that's what we have just started. We are going to start generating the debate. And if people are interested and have some know-how, I just saw one of the presenters from Ghana. They said the other facilities I was charging $12 per cylinder, and their hospitals, they are generating $80 per cylinder, and they have a committee. So we are also thinking about that. So we will be learning from you, the people who have experience, to make sure that we also stimulate the system in Malawi, so that at the end of the day, we don't have those troubles. We have a very well documented financial mechanism to fund this at the moment. Thank you so much.
Thanks so much, Norman. And I think that this is a really pertinent area of conversation for all of us that are interested in oxygen. The sustainability of oxygen generation plants is challenging. So it's really great to have this forum to be able to discuss that kind of thing. Thank you so much. So I think the next questions are from Sabina. And I think these questions are for quite a few of our panelists, actually. So would it be possible to share your experience on the tools being developed for oxygen use, as they're also working around safe oxygen use? And there's a second question as well regarding healthcare providers, but perhaps we can ask the panelists to answer the experience on the tools first.
Jane, do you want to take that one around the tools?
So I was pausing because the tools that we were highlighting in our technical resource were not so much around the use of oxygen itself in terms of like clinical use, but around the process of assuring its quality throughout the supply chain. So I wasn't sure whether the question was really focusing on the oxygen use. I did pop into the chat that WHO has recently released some key performance indicators for the medical oxygen ecosystem. So I think that's always a good starting point for countries to take a look at.
Thank you, Jane. This is Shabina. I'm sorry, I was unable to unmute myself. So my questions were more on the clinical, but thank you, Jane. And that link is quite helpful.
Yeah, can you come again with the question? Maybe I can attempt to answer.
So my question, I'm Shabina, and thank you for the presentation. I'm a newborn specialist working in LMIC in Pakistan. And my question was basically around the tools that you use to implement safe oxygen delivery. And they're more around the clinical aspects of safe delivery oxygen. So I was wondering, what is your experience with those tools, and would there be a potential, I mean, could you possibly share your experience or the tools? Because we are working around the same area, and I wanted to hear your thoughts of your experience that you've had in different hospitals from a provider's person's perspective. Thank you.
Okay, thank you so much. I think in Malawi, we have been doing implementing the sick newborn neonatal care units. And in that, we have developed the tools. We have the forms which we follow. And that has been most of the times we have been looking at CPAP, the use of CPAP, how they are using, the use of oxygen, how they are doing. And also now we have added the tracking system on how best we would like to track. And we are just starting discussing on how best can we make the tracking online so that we can move on and implement real-time data collection and others. So basically, I think when we train the health workers, we had to make sure that we are training the health workers on how best they can use the tools which we have developed, and also moving forward to say how best do we supervise, how do we make a mentor, and we get personal engagements as we move forward into the facilities. So we are sure also that I think if we can export the newborn care tools which we have used, the only exception which we had was to start thinking about how best do we quantify the oxygen which is required in this facility. But that was the issue which we are not doing. But I think in the new tools, we have in the central hospital, which I'm saying, we have embedded the oxygen indicators, which I think we are going to start using it at a clinical level to make sure that we are generating the tools as we move forward. And moving backwards, we will be also looking at how much oxygen came to this ward, how much oxygen have been used, and approximately how much oxygen we'll be able to calculate how much oxygen was the patient, could the patient have used in the period which he or she has stayed in the facility. Thank you so much.
Thank you, Norman, for that information. I also want to direct you, Shabina, to the NEST website, which was developed with a lot of input from global experts. And there's a lot of tools for clinical care around medical devices and safe oxygen use. So I think that could also be a resource, as well as looking at the Healthy Newborn Network, open for any of the participants to share their support with Shabina or their ideas. Over. So I think we have 5 minutes. We also have another question that maybe Norman could answer, or maybe Belinda from the COVID perspective around changing practices of healthcare providers.
Okay, fine. Maybe I will start, and my friend Belinda is going to finalize. To change we have moved on the COVID-19. We are stuck in a system whereby most of COVID-19 was a disease which was attacking adults, and now as we have moved in the neonates and children, we have to make sure that we are exporting what we have been learning in children to adults. So having that, where we have to, if you all know, we have been focusing as a group, we have been focusing on neonatal care, maternal health, and in child health, not mostly adult health. So these are the people who have now been hard hit. Now we had to start thinking about how best do we change the practices? How do we bring in oxygen into them? But consistent training, mentoring, monitoring, and the supervision has helped us to change we had at the policy level to develop new guidelines to do based on WHO guidelines. We had to develop them working with WHO and different partners. And I think Belinda talked about partnering with a lot of people. Some partners have finances, some partners have expertise, and the Ministry of Health has expertise. So we had to partner together to make sure that we are able to try to teach the health workers. And when we teach the health workers, we monitor them. And when we monitor them, we had to make sure that we mentor them when they have issues which we had to address. So that's how we have made that. But now we need continuous monitoring to make sure that the health workers maintain the skills. So in Malawi, in addition to the oxygen roadmap, we launched the emergency and critical care strategy, which is also looking at improving the care for the critical ill patients. And we have the steps in those, and we are trying to make sure that each and every hospital, they have the guidelines around them and the SOPs around them, so that every time they are managing the patients, they are able to do that. Thank you so much.
So thanks. I'll take over from where Norman left off. Indeed, we've also had varied experiences with healthcare providers. I wish I could say we've won it, but definitely supportive supervision has been one of our key strategies. Indeed, as I said, there was limited competency amongst biomedical engineers, for instance, and what the health service has done is it has built the competency of a pool of engineers that are sort of floating and are serving as mentors for the remaining biomedical engineers. And these have had their capacity built in medical oxygen equipment management. So that's one way we are doing it. When it comes to the issue of a proper care of the equipment that we are installing, we've realized training has been crucial. For instance, people don't realize little things as changing filters is so crucial. So we've seen people trying to hoover or blow out dust from filters, and just that proper orientation to clinicians who are the users of some of these devices at the bedside has been helpful. Partners have also had good results with putting clinicians and non-clinicians in the same room. So we realize that hospital management sometimes is not supportive of the oxygen ecosystem in the health facilities, or don't provide funds for maintenance, etc. And by putting these staff in the same training and giving them orientation on the issues around medical oxygen in the health facilities, that has also been helpful. Thank you.
So I just want to say thank you to all the participants and the speakers for taking their time to join us on this infrastructure webinar. If you have any other questions, please feel free to reach out, and make sure you look at the website to look for upcoming webinars. And thank you again to speakers and to Nest 360. Here's the website link. I hope everyone has an amazing remainder of your day.
Thank you.
Thank you.
Yeah, thank you.